be recorded.
Good afternoon to all. Today is the seventh lecture in this autoimmune disease series. For today's session, we have an eminent speaker and expert in this field, Dr. Raghavendra Pandilwar. Sir has completed BAMS and MD in Kai Chikitsa from YMT Ayurved Medical College, Kharghar. Currently, he is working as an associate professor in the same college, that is YMT Ayurved Medical College, Kharghar, in the department of Komar Bhritya. He is engaged in various workshops and like NABH training program, औषध निर्माण कार्यशाळा, and Chikitsa Tattwadarshan. He has published few articles like triple drug regimen in management of hypothyroidism. He has delivered various lectures on the topic of thyroid, which are organized by Ayurved Vyaspit Navi Mumbai, Maharashtra Association of Ayurved Students and Doctors, Ayurved Vyaspit Mumbai, Ayurved Vyaspit Panvel. Currently, he is working as family physician and thyroid consultant at Shri Siddhivinayak Clinic, Turbe since 2017. With this brief introduction, I request sir to start his session. Thank you. Sir, please start.
Sure. Thank you. So we will start with the session.
Yes, sir.
This is normal thyroid gland. So introduction. Thyroid gland is one of the most important and sensitive endocrine gland as it easily responds to the stress and stimuli. The global incidence of thyroid disorders increasing day by day. In autoimmune thyroid disorders, Hashimoto thyroiditis and Graves' disease are well characterized and interrelated disorders with a variety of clinical manifestations. Hashimoto thyroiditis is also known as chronic lymphocytic thyroiditis, is an autoimmune disease in which the thyroid gland is gradually destroyed. So today we are in brief, we are going to explain what is the Hashimoto thyroiditis, what are the complications, what are the causes, how to diagnose the patients of Hashimoto thyroiditis, and the most important part is the treatment of Hashimoto thyroiditis. Hashimoto thyroid disease is the most common cause of hypothyroidism in the areas of the world in which there is a dietary iodine is sufficient. So the hypothyroidism, there are two important causes of hypothyroidism. First is iodine deficiency and second is autoimmunity. Thyroid disorders have been correlated with the Galaganda, but all this type of correlation cannot satisfy the present demand. As mentioned by Acharya Charak, exact nomenclature is not necessary for all the diseases. It insists on diagnosis of the constitutional status of the disease, that is doshas. So this is the normal thyroid physiology. Everybody knows thyroid gland produces two important hormones, T3 and T4. Whenever there is a deficiency of these hormones, it gives a feedback. This is called as feedback mechanism to the pituitary. Pituitary releases TRS, that is thyroid releasing hormone, to stimulate the TSH, to stimulate the thyroid gland. Thyroid gland ultimately releases TSH. Pituitary ultimately releases TSH to stimulate the thyroid gland to release more and more T3 and T4. So these are the causes of hypothyroidism. Here you can see the most important cause of hypothyroidism is primary hypothyroidism, and out of this primary hypothyroidism, autoimmune thyroid disorders are the biggest cause of hypothyroidism in the present era. So what are the factors of autoimmunity? Autoimmunity, like genetic factors, plays a very important role. Then there are environmental factors. Then there are endogenous factors. There is a very big thesis on the leaky gut and the role of autoimmunity. Where we can see in daily practice, the patients of Hashimoto thyroiditis are gluten sensitive. So in these cases, we can stop the gluten. So what is the symptoms of Hashimoto thyroiditis? Hashimoto thyroiditis can come with the symptoms of hypothyroidism also. But in Hashimoto's thyroiditis, the main characteristic of the Hashimoto's thyroiditis is the presence of a goiter. So these are the signs and symptoms of the hypothyroidism. Like in general, patient will feel cold with increased weight gain with poor appetite, hair fall, shortness of breath, dyspnea on exertion, slow pulse rate, constipation, cold extremities, and irregularity in menses. In cases of hypothyroidism, in cases of Hashimoto's thyroiditis, you will see that there are symptoms of hypothyroidism with goiter. This is the characteristics of Hashimoto's thyroiditis. But you will see many patients who have symptoms of fatigue, sweating, presence of goiter, tremors in the hands, intolerance to heat, changes in the mood, and changes in the bowel movements. This is the very important diagnosis. This is called as Hashimotoxicosis. What do you mean by Hashimotoxicosis? Hashimotoxicosis is the first step towards the formation of Hashimoto's thyroiditis. That means in the first stage of thyroid, Hashimoto's thyroiditis, there is an increased amount of T3 and T4. Most of the doctors get confused to diagnose Hashimoto's thyroiditis is because of this Hashimotoxicosis. They easily diagnose this case as a hyperthyroidism, but it is different from hyperthyroidism. The symptoms are same like hyperthyroidism, but this is symptoms due to early leakage from the thyroid gland. So this is very, very important slide. I'm just repeating the slide again. In the first phase of Hashimoto's thyroiditis, there is increased amount of leakage from the thyroid gland. So the leakage of T3 and T4, which comes into the blood, will have the symptoms like sweating, presence of goiter, fatigue, tremor hands, intolerance to heat, changes in the mood, and changes in the bowel movement. So this is the first step of Hashimoto's thyroiditis called as Hashimotoxicosis. So how to diagnose the patients of Hashimoto's thyroiditis or any kind of thyroid disorders? Generally, we do investigations like T3, T4, and TSH. But my personal opinion and the proper diagnosis of the patients is like you should always do FT3, FT4, and ultrasensitive TSH. The reason behind it is T3, T4 will measure the total amount of T3. That is the free T3 and inactive T3, which is protein bound. So there are many patients we see, patients of pregnancy, patients who are taking OC pills and or any other systemic disorders, or patient taking any medications where there is a protein binding phenomenon is increased. In such cases, you will have a total T3 normal, but the actual patient was suffering from hypothyroidism. So next time, whenever you want to diagnose a case of thyroid disorders, always go for FT3, FT4, and ultrasensitive TSH. So what will be the difference between TSH and ultrasensitive TSH? TSH and ultrasensitive TSH, the only difference is the specificity. Ultrasensitive TSH is having much more specificity, so there are chances of errors minimized. These three tests, that's FT4, FT3, FT4, and ultrasensitive TSH, we do for the diagnosis of thyroid, the basic evaluation of thyroid disease. But for autoimmunity, right now there are three tests available. The first, which is very commonly used in practice, is TPO antibodies. Second is thyroglobulin antibodies. Third is TSH receptor antibodies. If you want to order a test for thyroid disorders or to diagnose Hashimoto's, which will be the more confirmatory test. So to diagnose the cases of Hashimoto's thyroiditis, there are two laboratory investigations which are very important. That is TPO antibodies and thyroglobulin antibodies. If you want to do only single test out of these two, so the test will be TPO antibodies. The reason behind it is TPO antibodies has a higher affinity and occurs in the higher concentration. So testing for TPO antibodies remains the single choice if the single test want to order. And to diagnose case, sometimes we require imaging to see the glandular changes. So this is the prevalence of thyroid autoantibodies, where we can see the general population's TSH receptor is almost zero. TSH receptor antibody test we now practically given only to the patients to diagnose the cases of Graves' disease. In Hashimoto's thyroiditis, we never do TSH receptor antibodies. You can see the specificity, 90 to 100% in the cases of TPO antibodies. So these are the important slides now. we need to diagnose first, then we can treat. The first is the horizontal line, which corresponds to level of TSH. This is the vertical line, which corresponds to level of FT4. So whenever in next time we will talk about T4, it will be always FT4. So if a patient comes to you having a report where TSH is in a normal range and FT4 is also in normal range. So this is a case of euthyroid. Euthyroid means patient is not having any signs and symptoms, or patient is not clinically into thyroid. Second case, a patient comes to you with a report of high TSH level and FT4 level is low. So this is a classical case of primary hypothyroidism. Most of the patient who comes to our clinic is of primary hypothyroidism, where you can see the TSH level is on a higher side and FT4 level is on a lower side. If a patient having TSH report is on a TSH on a lower side and FT4 is also on a lower side, these are the cases of secondary hypothyroidism. One of the most common causes of secondary hypothyroidism are the tumors, pituitary tumors, adenomas. These are also important cases where we can see in our daily practice where TSH is on a higher side and T4 is normal. This is called as subclinical hypothyroidism. Subclinical hypothyroidism means the patient not landed into thyroid disease, but it can land into thyroid disease after 3 to 6 months. Why the period is of 3 to 6 months? Because thyroid gland is the only endocrine gland which can store its hormone for the period of 3 to 6 months. So whenever the deficiency will occur after the period of 3 to 6 months. If a patient is having TSH report normal and FT4 report is low, so we can consider it as the patients of non-thyroidal illness. So these are the important slides. This is called as 9 square rule, where we can diagnose patients of euthyroid, primary hypothyroid, secondary, subclinical hyper, primary hyperthyroid, secondary hyperthyroid. So after evaluation of this, so our first step is to do free T4 level ultrasensitive TSH to those patients who are having signs and symptoms of thyroid disorders. After getting the result, you must diagnose the patient into primary euthyroid, subclinical hypothyroid, and then see if the presence of TP antibodies is there or not. I'm giving you a flow diagram where we can diagnose and the patients of Hashimoto's thyroiditis. Say if a patient comes to you with the signs and symptoms of hypothyroidism, the first step we are doing is serum TSH and FT4 level. We can see if the patient is having TSH level is on a higher side and FT4 level is on a lower side. So with the knowledge of previous slides, we can diagnose this patient as a case of primary hypothyroidism. In the same patient, we need to do one more test. The name of the test is TP antibodies. If the TP antibody is present, so we can label this case as a case of Hashimoto's. But if the same patient is having signs and symptoms of hypothyroidism where TSH is also increased, free T4 is low, but TP antibodies are negative. So this is not a case of Hashimoto thyroiditis. This can be a case of either transient hypothyroidism, post-mortal thyroiditis, or it can be a case of iodine deficiency also. Many times we see that patient says that we need to continue the tablet for lifelong. Generally, there is a belief of the patients that we need to take the tablets for lifelong. If the patient's TP antibodies is negative, there is no need to take the tablet for lifelong. Or in cases of Hashimoto's also, we can taper down the dose by 25 to 50 mcg and we can normalize the patients of Hashimoto's also. So reversal can be possible in both the cases. I can say that in cases of transient hypothyroidism or post-vital thyroiditis where TP antibodies is negative, 100% reversal chances are there. And in cases of Hashimoto's thyroiditis, I will still say 70 to 30% chances of reversal are there. If a patient is having same patient where TSH is also low, FT4 is low, we can diagnose this case as a central hypothyroidism. And to diagnose the cases of central hypothyroidism, we need to do MRI, CT of the brain to diagnose the cases like tumor, pituitary tumor, etc. What else we can evaluate from the patients? and the reports. Say we have a patient where TSH is more than 10, free T4 level is low, TP antibody is positive. So this is the case of primary hypothyroidism due to autoimmune cause. Same patient, but FT4 level is normal, TP antibodies is positive. So this is the case of primary subclinical hypothyroidism due to autoimmune origin. Patient having report FT4 level is low, TP antibodies is negative. So these are the patients of iodine deficiency, recovery from systemic illness and drug induced. You will see this kind of reports in many patients where we can see FT4 level is low, TSH level is increased. So first our diagnosis is basic is hypothyroidism, right? But if we see, if we do TP antibodies, we can see TP antibodies is negative. So that means this is not a clear case of autoimmune thyroiditis. In these cases, there are 100% chances of reversal. Patient generally reversed within 3 to 4 months of the treatment. If the patient is already diagnosed case or already taking some medication like ultroxin, Tylenol, then we can taper down the dose by 25 to 50 mcg. And the last diagnosis, which is very important diagnosis, you can see in your practice where you can see the free T4 level is elevated, but TP antibody is negative and TSH is also raised. We have seen our second slide where we can say that whenever there is a deficiency of thyroid hormones, it gives a feedback to the brain. So TSH is going to be raised. Here, FT4 is also elevated and TSH is also elevated. And this cannot be a case of hyperthyroidism because in hyperthyroidism, TSH is going to be on a lower side. So this is a new, we can say a diagnosis. This is called as thyroid hormone resistance syndrome. There are many patients of thyroid hormone resistance syndrome in your practice. We can see where FT4 is also elevated and TSH is also elevated. And the TP antibody is negative. So this is not any autoimmune cause, but due to the resistance to the action of thyroid hormones is there, and there is a blockage to the conversion of T4 and T4 to T3. I will give the treatment of these syndromes later. So I'm just repeating the diagnosis because my main focus is to proper diagnose the patients of thyroid disorders, though it is subclinical, primary, secondary, euthyroid, then Hashimoto's thyroiditis and central thyroiditis. So I'm just repeating for the second. If a patient having TSH level high, FT4 low, this is a case of primary. Both of the things are low, then these are the cases of secondary hypothyroidism. TSH level is on a normal side. FT4 level is say normal. These are the euthyroid patients. And presence of TP antibody positive with the TSH level on a higher side and FT4 level on a lower side. This can be considered the patients of Hashimoto's thyroiditis. If a same patient having same signs and symptoms but the TP antibody is negative, this can be considered as the patients of transient hypothyroidism, post-viral thyroiditis, or due to systemic illness. We have already seen the diagnosis. The only thing here is TP antibody. Presence of TP antibody is positive, can consider the patient into autoimmune. So this is a reversal, we can say a criteria where we can expect the level of TSH. Like if a patient comes to you with a primary hypothyroidism, the expected level of TSH is going to be around 6 to 500. In cases of iodine deficiency, it can be up to 150. Recovery from the severe illness up to 30. This is the same phenomenon we have just seen, thyroid hormone resistance, where we can see the TSH is not more than 20. In cases of psychiatric illness, TSH level is around 10 only. And in the cases of hypothalamic pituitary disease, it can be around 120. This slide can be used as a retrospective diagnosis for the thyroid disorders. Like we can diagnose a patient of thyroid by seeing the TSH level also. I just wanted to ask a question. What will be the highest limit for TSH level? I have mentioned it is 500, but what will be the highest level? Anyone? Or the upper limit of TSH? Please make the session interactive. The upper limit should be considered up to 1000. Okay. So what will be the Ayurvedic view of autoimmune thyroiditis or Hashimoto's thyroiditis? Hypo and hyperactivity. We have already seen in the patients of Hashimoto, in the initial stages of the Hashimoto, there is a hyperactivity. Like there is a leakage of the thyroid hormones which causes this hyperactivity, and when the stage is over, the patient landed into the permanent hypothyroidism. So there is a hypo and hyperactivity both present in Hashimoto's cases. So we can consider this is the cases of Vishamagni at the Dhatu level, mostly at the level of Medodhatu. Treatment of Vishamjwar is very helpful in the first period of the disease. First period of the disease is the period where there is a Hashitoxicosis is there. In the second phase of the disease, drugs useful in the hypothyroidism should be used because patient landed into permanent hypothyroidism. In the third phase of the disease, Rasayan Chikitsa can be incorporated. So this is the functions of Agni and related the symptoms to the thyroidism. Mostly we can see the Rasagni, there is the easy fatigability, dry skin, irritability, lack of sweating. As Artha with the Upadhatu, menstrual comes under Rasagni. And cases of Medagni, we can see there is a hyperlipidemia, obesity and goiter. Goiter formation we can easily see in the patients of Hashimoto thyroiditis, as it is one of the characteristic feature of Hashimoto's. So what are the dosha concepts in thyroid disorders? Kapha is always considered as a Mandagni. Pitta is always considered as a Tikshnagni. Vata Kapha, that is hypothyroidism, these are the chronic pathologies. We always consider these are the cases of Vata Kapha dominant. And Vata Pitta, that is hyperthyroidism, we consider as the cases of Vata Pitta as hyperthyroidism. In Hashimoto's thyroiditis, we can see in the first phase of the treatment, we need to treat Vata Pitta, and in the second phase of the treatment, we need to counter Vata Kapha. So this is the only one disease where we need to do two different treatments according to Avastha. Here only one treatment of Vata Pitta or only one treatment of Vata Kapha is not going to be helpful. So we need to treat the patient accordingly. So in the first phase of the treatment, always start with the treatment of Vata Pitta, and in the second phase of treatment, start with the treatment of Vata Kapha. So this is the normal thyroid physiology. So we are now going into the treatment part. Thyroid gland produces two important hormones, T3 and T4. And we are going, T4 is always gets converted into the T3. But sometimes T4 is also can get converted into reverse T3. This is due to one of the enzyme which is responsible for conversion of T4 to T3. The name of that enzyme is type 1,5 monodeiodinase, which is an important enzyme for conversion of less active T4 into more active T3. Here we can see whatever will be the pathology, the ultimate result is patient landed into hypothyroidism, or there is a underactivity of the thyroid gland, and there is a decreased production of the thyroid gland. So our treatment protocol should be, we need some drugs, we can stimulate the gland. Our aim is first is to stimulate this gland to increase the production of T4 and T3. Now our second target is convert the less active T4 into more active T3, because we can see there are multiple symptoms affected in the patients of, multiple systems affected in the patients of thyroid disorders. So our target is we need a drug having thyroid stimulant action, and we also need a drug who can convert the less active T4 into more active T3. So we have some drugs like Gugu and Kanchanar. These are the proven drugs who can directly have a stimulatory action on thyroid, and it converts the less active T4 into more active T3. We in thyroid disorders like in Hashimoto's, also in hypo and in hyperthyroidism, there is a mental symptom. To treat particular mental symptoms, we can use ashwagandha in these cases. If we further go in deep into the molecular level, we can see the T4 gets converted into T3 with the help of one of the enzyme. The name of the enzyme is type 1,5-mono-deiodinase. So what is the use of this enzyme? So this is the enzyme which we call it as a selenoprotein. If this enzyme is absent or this enzyme is not working properly, this T4 can convert it into reverse T3 also. Reverse T3 is a form of T3 which is inactive. Say in our body, if T4 is not converted into T3, but it is going converted into reverse T3, if the concentration of reverse T3 is more than 100 or 1000 also, but it is not going to activate our body. So for proper functioning of the thyroid gland or proper functioning of the hormones, we require the production of normal T3 hormone. And the production of normal T3 is totally depends upon the work of this enzyme, that is type 1,5-mono-deiodinase. For, as we previously discussed, this is the selenoprotein. To selenoproteins to act properly inside our body, we require good amount of selenium. That is one of the most common reason you see many endocrinologists prescribe selenium to the patients of thyroid disorders. The role of selenium is only to stimulate this. But there are many studies we can see where there is the amount of selenium is good in our body, still the activity of type 1,5-mono-deiodinase is decreased. The main reason is the absorption. So there are two main concepts of this enzyme. That is, one is production, second is absorption. Okay. So to absorb proper selenium in our body, we require a very good drug. We have a very good drug. The name of the drug is Pipali, which absorb the good amount of selenium in our body and do the proper functioning of less active T4 into more active T3 by increasing the activity of this enzyme, that is type 1,5-mono-deiodinase. So what will be the role of our Ayurvedic drugs? The first is Gugu. We have already seen, one of the best thyroid stimulant, can convert the less active T4 into more active T3. Second, Kanchana, we all know. This is also very good drug, thyroid stimulant, also convert the less active T4 into more active T3. Pipali, it increases the activity of the enzyme, that is type 1,5-mono-deiodinase. And Triphala. Triphala, one of the constituents of Triphala is Amalaki, one of the content useful in enhancing immunity, because we are dealing with autoimmunity. So here immunomodulator plays a very important role. And one of the key ingredient, if you see, these all are present in the case in the kalpa like Kanchana Gugu. There are all contents of the Kanchana Gugu, and there is one more content, and name of that content is Varun. Varun is very good drug in the cases to treat Hashimoto thyroiditis also. Varun is known as anticoagulant drug. Varun contains one of the protein called as eugenol, which helps you, which prevent the formation of goiters. As we have seen in Hashimoto thyroiditis, there is a presence of goiter. So Kanchana Gugu, one of the very good drug to be given in these cases also. What are the other drugs that can be given in the patients of Hashimoto's? In the first phase of the disease, I always say that in the first phase, either use Vidaryadi Kashayam or Drakshadi Kashayam. In the first phase of the disease. Hamsa Patadi also shown a wonderful result in the first phase of the disease. Vidaryadi Kashayam is the Vidaryadi Gana. Drakshadi Kashayam, it is this kalpa is in the Ashtang Hruday, Jwara Chikitsadhyay. Then Varunadi Kashayam and Gavarnadi, we have already seen Varun, antigoiter drugs which prevent the formation of goiter. So very good drugs. Kashayam and group should be selected according to the patient's condition and avastha. Rasanvati, combination of Guduchi Amalaki and Gokshur. Guduchi, excellent drug for immunomodulator action. Then Prabhakarvati. I use this Prabhakarvati in the first phase of the disease. As we have already seen, in the first phase of Hashimoto thyroiditis, there are palpitations, increase in the sympathetic outflow. Prabhakarvati is a very good drug to decrease the sympathetic outflow. It blocks the sympathetic outflow and one of the very good drug to be given in the first phase of the disease. Manasmitra Vatak can be used in both the cases like hypothyroidism also, hyperthyroidism also, where mental status is disturbed, mental conditions are there, mental symptoms are there. One of the best drug to be given. Contegana. Contegana contains 10 drugs. You can use Contegana in various conditions of the thyroid disorders. Gudushi we have already discussed. Shiguru. Shiguru is one of the important drugs. Shiguru is known as iodine plant. For production of thyroid hormones, you require proper iodine. Shiguru will provide the natural source of iodine and it can directly enter into the thyroid gland. Then Gorakhmundi. Gorakhmundi, very good drug, having ampachan properties also and very good activity on Manavasrotas. You can choose in between Manasmitra and Gorakhmundi also. If a patient is having proper goiter formation, you can use Gorakhmundi instead of Manasmitra. Because of Gorakhmundi is explained in the goiter stages, works very well in the goiter changes. Mandukparni increases the blood supply of the thyroid gland. So Shiguru, this is a research article where we can see the aqueous leaf extract of Moringa oleifera was evaluated for ameliorative effect in the regulation of thyroid in rat model. So what will be the results show that T3 and T4 were increased and TSH was decreased significantly at high doses compared to those in the control group. The results are only because of this is the direct, it contains direct amount of iodine. So there is an increased iodine production. Because of the production of thyroid hormones, you require proper amount of iodine. What will be the Ausha Sevankar? According to the Ayurveda, in Urdhva Chaturga Vyadhi, drug should be given at night. There was a study in Journal of Clinical Endocrinology where they have shown the finding of the study is very important. They have found that taking the same dose of levothyroxine at bedtime as compared to the first thing in the morning may be better. That means they are saying if ultrasound if taken at night will have a very good results. The results for this is bowel motility is slower at night, which means that it takes longer for the levothyroxine tablet to transit through the intestinal system, resulting in the longer exposure to the intestinal wall and therefore better uptake of the medication. The conversion process of T4 to T3 more effective in the evening. Patya, cabbage and cauliflower, sweet potatoes, soya should be avoided in all the cases of thyroid disorders. This contains natural goitrogens which causes the enlargement of thyroid gland. The smoking depresses the thyroid hormone levels. Alcohol and opiate increase the T3 by impairing the breakdown of T3 in the brain, thus lifted the mood. This might be the result of addictive nature of alcohol and opiates. Increased use of drumstick in the diet. Drumstick should be included in our diet, and the main patya is stoppage of cabbage and cauliflower. Now we can see the patients before and after reports. So this is the patient where TSH level is around 9. We have done anti-TP antibodies also. Anti-TP antibodies are 83. So according to our slide, TP antibody, these are the patients is having signs symptoms. We have done TSH and T4. This is the case we diagnosed as a case of primary hypothyroidism, and we have done TP antibodies. Okay. So TP antibodies are positive. So this is the case of Hashimoto's thyroiditis. In this case, there was no formation of goiter. The reason behind is this is the early case of diagnosis. And you can see this is the before repro where TP antibodies are around 83, and after the treatment of around 2 months, the antibodies comes normal to 18. And before TSH, before treatment, the TSH was around 9.6, and after the treatment, it comes around 4.2. We have then shifted the patient to the maintenance therapy, and in the second follow-up, the patient's TSH was around 2.5, and in the last follow-up, the patient TSH was around 2.4. This is a very classical case of Hashimoto thyroiditis. Early diagnosis is the key. This is my patient where I have patients report around 6 months also. The patient never landed into hypothyroidism again. This is our second patient where you can see the TSH level. TSH is more than 100. And TP antibodies are positive in these cases. This is a case of Hashimoto's thyroiditis. And after the proper treatment with the medications explained, the TSH comes around 1.5. This is the case of Hashitoxicosis. There we can see the patient TSH level is 0.03. That means this patient landed, this is the early stage of Hashitoxicosis where TSH is around 0.03, but this is not a case of hyperthyroidism. So we have started the treatment of Vishwamjvar here. Then after follow-up, the TSH comes around 2.7, that is in a normal range. Then after 3 to 4 months, the TSH was 2.02, so this TSH is maintained in this patient. Then again, TSH was 4.9. I have reports of more than 3 years of these patients. The patient is completely cured. I have a testimonial, video testimonial also of this patient. So in all the cases, the main line of treatment is the early diagnosis. If you early diagnose the patient, then there are very, very good chances of reversal. So thank you. If anyone has any questions, please ask.
Hello, sir.
Yes.
Is there any role in Hashimoto's thyroiditis?
Is there is, sorry sir, is there is?
Any scope of Panchakarma or Shodhan Chikitsa?
Yes sir. In thyroiditis, in the second phase of the treatment, there is a huge role sir. We can do Nasya also in the cases of Hashimoto's, and Chikitsa, Panchakarma like Basti we can do in this patient sir. Nasya I use this Amrutadi tel, Sushruta reference. And in the first phase of Hashitoxicosis, we can give Bastis of Panchatikta. Panchatikta Gurutakshur Basti we can give.
What about Vaman?
Vaman in Hashimoto's thyroiditis I never tried sir, because in first phases of Hashitoxicosis Vaman should not be given. In the second phases you can give if there are a lot of symptoms of hypothyroidism are there.
Yeah, because hypothyroidism cases are very much good responding to the Vaman therapy.
Yes sir. But in the first phase you should not give, because the first phase corresponds to Hashitoxicosis, no?
Okay, thank you, sir.
Second phase you can give, sir.
Second phase, yeah.
Yes.
Is there any local application you have used, like leaf?
Kukutnaki leaf I am using in the patients of Hashimoto's where there is a goiter formation. You can use Kukutnaki leaf also.
So, like how many days, like you have to?
15 to 1 month, there is no problem. You can apply it daily at bedtime. Nasya plays a very good role in goiter formation. To reduce the formation of goiter, daily Nasya should be advised. Nasya of either Anu tel, Panchandri Vardhan tel. I use a Samrutadi tel more in the cases of Hashimoto's also.
Okay, like Prativarsha daily.
2 drops. Prativarsha Nasya should be given.
Option for Lepan is Kanchanar Shal, Kanchanar bark. That is also for local application.
Yes,
So giving results.
Yes. The main part of the slides are the investigation and diagnosis. Before start any treatment, diagnose the cases properly. Because most of the times I see practitioner directly start with Kanchana Gugu in all the cases. It will not give a good results in Hashitoxicosis. Rather, patient symptoms are going to be increased if you start Kanchana Gugu to the Hashitoxicosis patient. So my sincere request is diagnose the patient properly, then start the treatment.
According to how much percentage of like people like with hypothyroidism have this hypotoxis?
Sorry, ma'am, can you please repeat?
The Hashimoto, this thyroiditis, how many like percentage or how many people, like it's a low percentage now with this patient?
No, ma'am, it is not a low percentage. We didn't diagnose the patients properly. If you do TP antibodies in every patient, you will see many patients of Hashimoto thyroiditis because it is one of the leading cause of hypothyroidism. I would say every third patient is Hashimoto's. The thing is, patient comes to us very late, and at that time, patient landed into hypothyroidism. And our diagnosis, we only calculate FT4 and TSH. So we say this is a patient of hypothyroidism, but we never see the cause of hypothyroidism. If we see the cause, we can easily find out the patients of. The only thing how we can do is do TP antibodies in every patient. So it will give you two things, like you will have a proper cause of the hypothyroidism. And second most important is you can easily say this is a progressive disease or this is a normal hypothyroidism. If it is TP antibodies is negative, so this is the patient which can easily reversible. The patient gets reversed in just 3 months or 2 months. But if it is Hashimoto's where TP antibodies is positive, you should have to continue the treatment for 6 months, or the patient is already diagnosed, then you need to taper the dose very carefully.
Okay, sir. Thank you.
You can include pranayam also in the patients of Hashimoto's or thyroid disorders. Ujjayi pranayam is one of the pranayam should be started in every patients of thyroid disorders. Because
Yes,
there
sir,
are vibrations.
Brahmari pranayam.
Yes, sir. Brahmari pranayam is very good. Because there are vibrations in the throat region that ultimately stimulated the gland.
How come this Hansapadil Kashar, like as a drug, how you can explain it more? Like how it is.
Hamsapatadi Kashayam, if you see, ma'am, Hamsapatadi Kashayam is a combination of 5 drugs. So it contains Hamsapadi, then it contains Guduchi, it contains then Neem and Vasa and Pippali. So I use this Hamsapatadi more where there is a formation of goiter. Because Hamsapati is a drug which is very good for prevention of goiter or to reduce the size of the goiter. And if you see, Hamsapati can be used as a thyroid regulator. So this is I think one drug which can use in both the cases of hypo and hyper. I never use this in the patients of hyper actually, but can be used in hypo and hyper also. And Guduchi, very important drug for immunomodulator actions. It also contains Neem. Neem is a very good and proven drug for hyperthyroidism. And then it contains Vasa and Pippali. Pippali we have already explained, very good for absorption of selenium. So can be used in the avastha where there is a formation of goiter is there and TSH is fluctuating. Like patient landed into, if we taper down the dose completely and then also patient landed into hypothyroidism, in these cases or where we see fluctuations of thyroid levels are there, you can use Amsopatadi.
Sir, if you don't mind, can you please tell them, like, from the Ayurvedic point of view, the Samprapti, like how it is. Yes. If you have seen many people, so like what is the like maximum times what Samprapti happens like?
The Samprapti, if we say of Hashimoto thyroiditis, no, after thyrotoxicosis, at least 6 months are required to land the patient into hypothyroidism. And for direct fibrosis of the glandular cells, it will require years.
And sir, even in like in a hypothyroid patient, like from Ayurvedic point of view, like it is sometimes considered as Pandu or the various these are there.
Like, my view is we should not label the patients of thyroid disorders. That's why in introduction I have mentioned ki, you can correlate with the different diseases, but you should not label the disorders because they are quietly similar, but they are not exactly similar. If you say what will be the differential diagnosis, I would say Kafach Shotam, Kafach Pandu can be considered as a diagnostic or having similar diagnosis to this hypothyroidism. So drugs explained in Kafach Pandu, Kafach Shot can be. I use this Punarnama very often in the patients of hypothyroidism. Punarnama Mandur is very good drug in the cases of hypothyroidism. So that can be correlation should be there, but should not label it.
And the role of Gandamala Kandan, sir.
Yes, very good drug, having very good concentration of Mandur and Punarnava. And I think it is the only, please, if I'm wrong, please correct me. I think it is one of the few drugs where there is a Kanchanar. Kanchanar associated Rasakalpas are very few. If anyone having, say, more Kalpa knowledge of Kanchanar, please, because I came to know there are very few drugs which is having Kanchanar in Rasakalpa. Gandamala Kandan is a good drug, can be given. Actually, I use this Gandamala Kandan Ras in the patients where thyroidectomy is advised. Right now, we have more than 5 patients, so where we successfully avoided thyroidectomy. If anyone wants, I can share the details. In these patients, I use this Gandamala Kandan Ras. So there are cases where thyroidectomy is advised in the patients. In that cases, Gandamala and Kandan Ras, I use this along with Varunadi growth. You can try this combination. It's worked wonderfully.
Same doses of Gandamala Kandan, 125 milligram. How much is it?
1 BID, 1 TDS you can give, no problem.
Okay.
And Nasti should be given along with medication. Nasti of either Shadbindu tel or Panchindriya Vardhan tel. Or if you can give Amrutadi tel also. It is available in one of the pharmacy. You can use this Amrutadi tel.
Okay, sir.
Any more questions?
I would like to know the reference of Amrutadi Tail, whether it is Guruchi based.
I will send you, sir. It is in Sushil Sanhita. I will give the exact reference. One second, I will give the exact reference.
Just to know the more details about this formulation.
Yes,
Nothing.
Yes, I am giving.
Sir, and the difference, like let's say that point to use Monomitram and Gorakhmundi, that also please you can explain more.
Yes, ma'am. Sir, Sushrup Sanhita, Chikitsa Adhyay, 18/47.
It's 18. Yeah, thank you.
Yes. What was the question? Manas Mitra and?
This Gorakhmundi, sir.
The difference is?
Difference when to use, like we're saying now that like when.
See, actually, this is my area of choosing it. How I choose is, if a patient is having, say, signs and symptoms of thyroid disorder with formation of goiter, and mental disturbances or mental psychosis patient, mental symptoms are less, and goiter formation is more. Because Gorakhpundi is a drug explained in very good Ampachan drug and having very good activity on Manavasthrutus. And in our text, the Gorakhpundi explained in the say Galaganda, Gandamala, and Arbut. So formation of tumors, formation of adenomas. In these cases, Gorakhpundi works very good. If you want to give, say, patient is not having overgrowth symptoms or patient is not having goiter formations and patient more like having mental symptoms. In that case, instead of using Gorakhpundi, you can use Manas Mitravata. Because Manas Mitravata does not have any activity on excess growth.
Okay, sir. And so, hypothyroid patient, like if there is just the swelling on the neck region, then we can use like along with Kanchana Gugu this Gorakhpundi Kada.
Yes. Gorakhpundi Ganavati is also available. You can use. In fact, in my practice, I never use Kanchana Gugu single. I have my own combinations where Gorakhpundi is always there.
Okay.
So you can prepare a drug where you can add Kanchana Gugu, same combination with Gorakhpundi also, or you can use as a Bhavana Dravya. If you see Vaishya Ratnavali, the slok of Vaishya Ratnavali, where they say ki Kanchana Gugu should always be used with Gorakhpundi Anupan. You will have that reference in Vaishya Ratnavali.
Okay. Sir, and can you just tell the dividing line when we can use when we start using Rasayan toxin in these patients? Like what are the like exact
stage of starting Rasayan Chikitsa?
Yeah. Because
you can
you along with this medicine only we can start it, or there is some like difference.
You can start it, ma'am. You can start it. Or whenever you completely successfully taper down the dose, then you can start the Rasayan treatment. Or you are if you are done Panchakarma treatment, after Panchakarma treatment you can start the Rasayan treatment. In cases of hypothyroidism, mostly Brahma Rasayan is good. Then Chitra is good in cases of hypothyroidism. Shiladi also is good. Most of the times, patient comes to you with not only a single diagnosis. So at that time, with comorbidities, you need to calculate the dose, calculate the drug.
Chitra is Ushna na quite messy.
Yes, sir. Yes, ma'am. That's why it should be given in hypothyroidism, not hyper.
Okay. It will be like for limited time only, we can use it.
Yes. You can use Rasayanvati also. Good drug.
Okay. So like dose of Rasayanvati will be like how much?
You can give 2 tablets with honey if you want. You can use Shiva Gulik also. Good drug to be given should be used as a Rasayan also.
Okay. It will be OD.
Yeah. Yes.
Even Bhallatak Rasayan is also good.
Yes, in hypothyroidism.
Yeah, hypo.
Any questions? Or should we?
If all questions are over, we may conclude this session for today.
Thank you, sir.
I think all questions are over now.
Okay, thank you, sir. Yes.
Thank you.
Thank you, sir.
जंगल में डाल दिया बोरा